If we are going to start out the USMLE practice questions about the immunology. A researcher identifies a group of malignant epithelial cells in the sigmoid colon that have decreased their surface expression of MSC class 1 antigen. Which of the following immune effector cell types is most likely to kill the transformed epithelial cells? In that, these are malignant cells that lose the MSC class 1 expression. And if you guys remember the function of natural killer cells in the immunology, there is one line that the cells that don't express or decrease their surface expression to MSC class 1 antigen that are going to kill by natural killer cells. The natural killer cells are responsible for the destruction of the cells with decreased or absent MSC class 1 protein on their surfaces. Such changes in MSC class 1 antigen expression occur in virus-infected cells and tumor cells. The natural killer cells are derived from the lymphoid stem cells and comprise approximately 10% of all circulating lymphocytes. They are large cells of cytoplasmic granules containing perforins which produce holes in target cell membrane, and grain enzymes, which are the substances that are having the perforins and grain enzymes. Grain enzymes are chemicals that induce the target cell apoptosis. The grain enzyme gain access to the target cell via the membrane holes created by perforin. The target cell subsequently undergoes apoptosis. The natural killer cells do not retain lysis cells. Actually, the natural killer cells, what are basically their functions and what they don't express? Actually, the natural killer cells do not express CD4, 8, and 3 molecules on their surfaces. They do express either CD56 and 63, and they don't require the thymus photomaturation like T cells required, and they have no antigen specific activities. They don't require exposure to antigen for activation. No antigen activation needed, and they are activated by, this is one of important question, the natural killer cells are activated by interferon gamma and interleukin 12. It's a very important point. Okay. Now we are moving to my next question. Our next question is about 18-month-old partial vaccinated boy is brought to the office for a routine well child examination. His parents had elected a delayed schedule for a vaccine administration based on personal preferences. Today, the patient is scheduled to receive the Haemophilus influenza serotype B conjugate vaccine. The parents are given detailed information about the vaccine, but the mother asks why is the tetanus toxoid nested on the package insert. She adds that her son already received the diphtheria tetanus erysiperosis DPT vaccine. The parents request an explanation for the reason. The HIB vaccine contained both the capsular polysaccharide of HIB as well as the conjugated tetanus toxoid. Which of the following best describe the purpose of HIB vaccine conjugated? This question is regarding the principle of immunology, in which the parents are concerned about the vaccine, why you are giving the conjugate vaccine and also the conjugated tetanus toxoid with the capsular polysaccharide vaccine. So guys, the immunogenicity of polysaccharide with a conjugate vaccine, we have to elaborate. I having this table with me in which the polysaccharide vaccine are going to get response type of a B cells, and a polysaccharide protein conjugate vaccine that we are giving to that child, it giving response to B and T cell both. the polysaccharide vaccine can't give a mammary cell response. So, polysaccharide protein conjugate vaccine are giving mammary cell response. In polysaccharide vaccine, the relative duration of immunity is very short. But in polysaccharide protein, when you're having the conjugate vaccine, having a long duration of immunity. And immunogenesis infancy, it having no, in this, it having the immunogenicity in infants. So for that reason, we are having that option. So which one will be the right option? The right option is, it will elicit the T cell dependent immune response. Understand? Because when we are giving a polysaccharide protein conjugate vaccine, it will give the response type of B cell and T cell, both. The Haemophilus influenza serotype B vaccine consists of capsular polysaccharide conjugated to a carrier protein like tetanus toxoid protein or the membrane protein of Neisseria meningitis. The protein conjugations causes a T-cell-mediated immune response leading to long-term immunity through production of mammary B lymphocytes. So for that reasons, we are giving that polysaccharide conjugated vaccine. If we are moving to our next question, our next question is about an autopsy is performed on an 8-month-old infant after his unexpected death. Prior to death, the patient had a 1-month history of a poor feeding and intermittent fever, which progressed to severe lethargy and a coma. The infant was adopted soon after birth, and there is a limited information about his family history beyond the documentation of an uncomplicated pregnancy and a delivery at a term gestation. They are uncomplicated. Brain biopsy in the air reveals the leptomeningeal inflammation, and it's a positive for enterovirus by PCR. This patient would have been most likely to have which of following laboratory findings? Well, first we have to make a diagnosis. The enterovirus, they are giving. The enterovirus is the most common infection in children that typically causes a self-limited disease. Such as Herpesingina, foot and mouth disease, or in some cases, aseptic meningitis. However, because neutralizing the antibodies are required to clear enterovirus, the severe life-threatening infection can occur in the primary hormonal immunodeficiencies such as XLA, like X-linked A-gamma globulinemia. X-linked A-gamma globulinemia. In this, it's also called the proton A-gamma globulinemia. And it is due to the mutation of BTK gene. And in this, that is going to encode, that BTK gene are going to encode proton tyrosine kinase. It is a defect in this protein prevents the PB cells from differentiating and exiting the bone marrow. Therefore, the patient have the low circulating B lymphocytes. If we're having the low B lymphocyte, and it automatically having a less or low immunoglobulin level. So in addition to enteroviral infection, the XLA also increases the risk for recurrent cytomegalovirus infection by encapsulated bacteria like Streptococcus pneumonia, Haemophilus influenza type B, which require the antibody opsonization for phagocytosis. And secondly, a patient with an impaired hormonal immunity also predisposed to gastrointestinal infection like Salmonella Campylobacter as well as the chronic giardiasis due to low secretory IgA. And this was a case of X-linked agammaglobulinemia. So our answer will be, what will be the laboratory finding? It having a low circulating B lymphocyte count because it is a patient of X-linked agammaglobulinemia. If you guys know the clinical manifestation, they have a recurrent sinopulmonary and the gastrointestinal infection at the age of 3 to 6 months. And secondly, if you go for the laboratory findings, there will be decreasing immunoglobulins and antibody response to vaccine. Secondly, they are having the flow cytometry in which there will be decrease in CD19 B cells. But they are having normal T cells. Understand? Now we are going for our next question. Our next question is about a 62-year-old woman that is admitted to hospital for living donor kidney transplant. She has a history of end-stage kidney disease due to diabetic nephropathy and has been undergoing hemodialysis for last 2 years. The transplant surgery is performed without complication, and the patient demonstrates good urine output afterward. To help to prevent the rejection, she is given a medication that inhibits the conversion of inosine monophosphate to guanosine monophosphate, primarily in lymphocytes, causing to reduce proliferation of activated lymphocytes. Which of the following medication is most likely being used in this patient? And we have to give and total about one medication or medicine that going to inhibit the conversion of inosine monophosphate into guanosine monophosphate, primarily in lymphocytes. Understand, guys? It is mostly happen in de novo pathway. If you guys remember the de novo pathway, in which the ribosome 5-phosphate are going to convert to PRPP and it will going to convert in inosine. I will make the ribose 5-phosphate going to convert it PRPP, that is going to convert into inosine monophosphate. PRPP stands for phosphonylbioside pyrophosphate. And second, H3 we are going to convert in guanosine monophosphate, and that will be helping DNA and RNA synthesis. So which drug are basically going to inhibit that? That is mycophenolate. Answer is mycophenolate. This is one of important table you guys have to be memorize, make it strongly in your brain. This is one of important topic. An important table in which all the drugs are mentioned in that the mycophenolate are going to stop in and inhibiting the nucleotide synthesis. In this nucleotide synthesis, DNA RNA synthesis, we are going to inhibit the inosine monophosphate into guanosine monophosphate. Okay, so answer is mycophenolate. But that is very important. There is cyclosporine, tacrolimus, that is going to inhibit calcineurin, and there also one question about like sirolimus that is going to inhibit mTOR to decrease the expression of interleukin-2 receptors. And also glucocorticoids are also going to inhibit NFKB to decrease the inflammatory gene transcription like that. Understand? Now we are moving to our next question. Our next question is about a research. The pharmacology researchers are developing a new antivenom to treat coir snake bites. They immunize the horses with a snake venom, extract IgG containing plasma, and then administer the plasma to humans who have been bitten by collared snake. This therapy neutralizes the venom and improves the patient's symptoms. Nice job. In order to produce venom-selective antibodies, the researchers select a single venom-specific plasma cell from the immune zone and induce it to proliferate and produce large amount of venom-specific IgG. However, they find that the antibody produced by the single plasma cell is less effective at neutralizing the venom than IgG containing. A decrease in which of the following best explain the reduced efficacy of immunoglobulin produced by single plasma cell. Okay, fine. If you guys know, this is a very important topic one again. Actually, they are asking about the monoclonal and polyclonal antibodies. If you guys know about the monoclonal, they are derived from single B cell population, and it is derived from multiple B cell population. They are having a single antibody type, and in polyclonal, they are having a multiple different antibodies. And in monoclonal, they bind the single epitope on NCG. Bind to single epitope. In polyclonal, they are going to bind different epitopes. They are highly specific. They are highly specific response to antigen. In polyclonal, they are having the broader response because they are going to bind with different epitopes. Understand? They are going to bind with different epitopes. They are having the multiple different antibodies and also producing multiple B cells. So they can overcome the multiple antigens. So due to that reason, they are having a more efficacy. And the following whatever question, therefore best explain the reduced efficacy of immunoglobulin produced by single plasma cell. So in polyclonal antibody, they have more efficacy because they are going to recognize number of antigen epitome more. Like they are going to recognize different epitopes, but in monoclonal, they are going only recognize only one single epitome. So polyclonal having more efficacy, if you guys say like that. The plasma contains polyclonal antibodies, a pool of antibodies that bind different epitopes on an antigen. In contrast, a monoclonal antibody binds a single epitope on an antigen. The polyclonal antibodies are often better at neutralizing the complex antigens because they contain antibodies that bind several different epitopes. Now we are moving to one more question. And this one question is about a 10-month-old boy that is hospitalized for respiratory distress due to pneumocystis jirovecii pneumonia. The patient has repeated episodes of otitis media and thrush weight is below the 5th percentile. Laboratory evaluation reveals a normal level of circulating B and T cell with low level of all immunoglobulins. The genetic testing reveals a rare autosomal recessive mutation resulting in a defect in the regulation of human leukocyte antigens. Flow cytometry of the patient peripheral blood compared with the healthy control is shown in this illustration. Now what we have to find, which of the following processes is more likely to be impaired by this patient mutation. Okay, we have to read this flow cytometry. In this flow cytometry, if you guys focus, upper one is about the patient, lower about healthy one. If you guys focus, they are having CD19. Their CD19 is a mark of a B cell. If you can make a difference between both the graph, they are same. There's no difference. So CD19 is normal. If CD19 means normal, then it means it having normal B cells. Because CD19 is surface marker of B cell. We are having CD3. The CD3 is the surface marker of normal total T cells. So it is also same in both graphs of cytometry. If you guys focus, making a same flow like that. So it is also having normal T cell, total T cell. If you move to the next graph, they are having same CD3. The CD3 is normal T cell. But if we focus on the HLA-DR, they are having this color and fluorescent, but there is a missing. So it means it having the absence of HLA-DR positive cells. Understand? So what they are saying? They are saying which of the following percent most likely to be impaired by this patient mutation. He having the mutation of HLA-DR that indicate that defective expression of major histocompatibility complex class 2 molecules. If you guys remember, like they having the HLA-A, HLA-B, HLA-C, having one letter mean they are having association in MSC class 1. One letter. If there are two letters, HLA-DP, HLA-DQ, HLA-DR, they are having association in MSC class 2. So, if the mutation of HLA-DR is there, then there will be defective expression of major histocompatibility complex of class 2 molecules. The human leukocyte antigen that encode the MSC molecule expressed on surface of antigen presentations, and these all the major loci in which DP, DQ and DR are encoded for MSC class 2 molecules, and they are going to express antigen presenting cells like on B cells, macrophages after the extracellular antigen has been loaded onto MSC class 2 in a acidified lysosome. So now it having the impaired function in antigen presenting. So there is one option, there is a impaired presentation of antigen process in lysosomes. This is our right answer. Now we are moving to our next question. The next question is about a 23-year-old woman that comes to the office with a sharp right-sided chest pain, fatigue, and a fever. For the past week, the chest pain is worse with a deep breathing. She has had no associated expectoration or shortness of breath. For the past 6 months, the patient also had intermittent joint pains, predominant in the knee and the hands. Sexually active with one male partner using an intrauterine device for contraception. Temperature is 100, the blood pressure 120/70, pulse is 89, respiration normal. The BMI also normal. Examination show mild erythema sounds, erythema over the cheeks and scorching sound over the right lower lung with breathing. Heart sounds are normal. There are no joint swelling. Which of the following tests is the most useful? We have to say the test. Which tests are useful in confirming the diagnosis? According to signs and symptoms, this patient have constitutional fever, fatigue, and the weight loss, like that symptom. Also having the arthritis, pain, and if you guys focus, they're also having intermittent joint pain and also having the rash over the cheeks, like butterfly and photosensitivity, the butterfly rash and photosensitivity, like psoriasis, hepatopruritus, pericarditis, that giving a right-sided chest pain. These all symptoms, clinical symptoms, going diagnosis of manifestation of SLE, that is systematic lupus erythematosus. And secondly, for that, for the particular autoantibodies that are useful in the diagnosis of SLE includes anti-nuclear antibodies. Second is anti-double stranded DNA antibodies. And secondly, we have one more we're having, that is anti-Smith antibodies. And anti-nuclear antibodies, if you talk about this first, are found in virtually all patients with SLE, but also in many other autoimmune disorders. So it is a high sensitive but low specific. Okay. And secondly, in anti-double stranded DNA antibodies are highly specific for HLE. Yeah. Highly specific. Highly specific for the SLE, but not approximately 60% of patients have high titers. It have a low sensitivity because 60% of patients don't having as much base number. The anti-Smith antibodies are antibodies against the small nuclear ribonucleoproteins that represent 20 to 30% of patients, but also have highly specific. But the common laboratory abnormalities include necessarily are low C3 and C4 level due to activation of complement and elevating inflammatory markers like C-reactive protein, hydroxide, sedimentation rate, etc. So our right answer, what is our useful diagnostic molecule? That is anti-double stranded DNA antibodies. That is a highly specific for SLE. Now we are about the next question. Our next question is about immune response in a healthy 12-year-old boy that is observed after a recurrent bacterial infection. It is characterized by a rapid increase in pathogen-specific immunoglobulins level. Age of 12-year-old boy. The immunoglobulins bound to the bacteria also attach to phagocytotic cells like macrophages, neutrophil to enhance the phagocytosis, and which of the following immunoglobulin regenerate most likely involved to interact with the phagocytic cells. Now what is they are asking? The immunoglobulin are going to interact with phagocytic cell. Which part of immunoglobulin will interact with phagocytic cell we have to get. For that, first we have to go for the structure. Okay. The immunoglobulins are composed of a pair of light and heavy chains that are linked by disulfide bonds. They are having pair of light and the heavy chains. And the light chains contain the variable region and the constant region. The heavy chains contain the variable region and 3 to 4 constant regions, CH1 to 4. And the functional structure of the immunoglobulin is broadly divided into following components. That is a FAB, like FAB, that site for attachment of an antigen, this one. And this one is a site of attachment for phagocytic class. Phagocytic cells, that is FC region. And also it is a site for the attachment of complements. So the Fab fragment is the entire light chain plus the variable of the first. The Fab is equals to, you can write that, light chain plus They're having the variable and the first constant region of the heavy chains. Variable NCH1, and this Fab binds to specific epitopes on the antigen using a hypervariable cluster of 110 to 130 amino acids and invariable portion of molecules. Now we talk about the Fc fragment is the remaining constant Fc region, the remaining constant region of heavy chains. And the Fc fragment is the effective portion of immunoglobulin that going to interact with immune cells and complement system. So which of the part is most going to go for the interaction? The Fc region. The Fc region having the heavy chains. So our answer will be the constant region of heavy chains. Mean Fc region is going to interact with immune cell or phagocytic cells. It's all about today. Thank you.